patient. The patient's going to tell you what they're doing. If you get a SAT of 50 and you see that they're breathing and they look pink, that 50 is not right. Most likely, if their hand is cold, it's not placed properly.
Right.
So you have the ability to use it on the ear, warm the hand up with a washcloth. So what that pulse oximeter is doing, it's sensing the amount of oxygen that's saturated in the hemoglobin of the blood. All right, so we all know that we want that, you know, in the 90s in an ideal situation.
So basically the pulse oximeter is going to give us rate, it's going to give us rhythm, it's going to give us oxygenation, and it's going to give us pressure. Because like Nancy says, it needs to have that pulsatile flow. So if your pulse oximeter is not working and you have ruled out that it's poor placement, that the pulse oximeter itself is not working, you really need to start to entertain, maybe I'm really severely hypotensive. Even though I might have an EKG, you can have EMD, right? Electromechanical dissociation. So really, it is probably one of the best monitors that we have to see how a patient is doing, okay? The problem with the pulse oximeter is the lag time that it has, where your percent of oxygenated hemoglobin might be much higher than what it's reading. You might be at 90 and it's reading 50. Mm-hmm. And that's why, like Nancy said, you have to look at the patient. If the patient is starting to look pinker, if the patient is starting to look like they're not at 50, believe that, okay? So that's our pulse oximetry. What are our most frequent problems here in our suite? It's usually during uppers, right? And what are the three things that I think and that Nancy thinks causes the biggest problem? Secretions, airway obstruction, and decrease in respiration. So Nancy, you want to take secretions?
Yeah, I mean, if you think about it, no one wants a stroke down their esophagus, right? I mean, everybody's going to be, I don't want that, I don't want it. I feel, I like the idea of giving Robenol, yes, and just, even if it's a subtherapeutic dose, at least drying somebody out a little bit, just to prevent an overabundance of secretions. You'll even see that in a non-smoker. I mean, people just don't like to be intubated with any type of anything. So, secretion, so, you know, to me, I mean, you know, my experiences in suctioning in the hospital, we would use trumpets, we would use the soft suction. Yes, you have the Yankauer. It's kind of mean if you think about it, when you're suctioning people hard with that Yankauer, that's a hard piece of plastic. You see people shoving it down, you get, you know, trauma. I mean, ideally, you can soft suction orally. We don't have trumpets here. I mean, we don't really want to suction people nasally, but you can.
So we have our soft suction catheter, everybody knows, and we have our Yankauer catheter, okay? If somebody is having a lot of secretions, really, like Nancy said, the best thing is this soft suction. Just pull their jaw down a little bit, and usually you can get that in there.
Yeah, you kind of go along the side.
You're not going to get this in. Yeah, you go along the side.
Right. 25? Okay.
Airway obstruction. What is the airway obstruction from? It's from the tongue, okay? It's from the tongue falling back. So that's really a big problem. Not a problem, but it's a big event that we see that happens here. So what do? We do a jaw lift. Nancy, please explain how you do a great jaw lift.
So well, the patient will probably be in pain after. They'll complain that they're sore, especially when they go home. But you want to actually press in and lift the jaw out, so that you're actually changing the anatomy. That tongue is now not going to occlude that airway. You're getting it out of the way. I mean, just that alone, if it's the technique is correct, will help the patient considerably.
How long the tongue is, how far back it goes into the posterior pharynx. So it's the relaxation of all that soft tissue that causes airway obstruction. So first thing, like Nancy said, jaw lift. What's the second thing we might want to do then? Is put in an oral airway, okay? We have 3 size oral airways. Red, which is the biggest, yellow, which is the medium, green, which is the smallest. It's important to put in the right size oral airway. A poor man's way of measuring the right size, Nancy, can you explain that?
Is just holding the actual airway and looking at it this way and see exactly where how far it's going to go down.
In general, a red or a yellow for a man, a yellow or a green for a woman. If you're putting in an oral airway that's too small, it's not gonna help you. It will actually sabotage
right.
you, okay? It will not help you. Do not put in a green oral airway in a 6'1", 200-pound guy. No
He's gonna
bueno.
swallow it.
Don't put this airway in me, because this is gonna go and hit my vocal cords, and guess what's gonna happen? Laryngospasm, exactly, okay? So it is important to pick the right size oral airway, okay?
And of course, you suction right through the oral airway.
Right, our soft suction, that's a great point, our soft suction goes right through the middle of this, okay? So secretions, airway obstruction, decrease in respiratory effort, or perhaps an absence of respiratory effort that occurs during primarily an upper, because we have to get our patients very deep, okay? What do we do for that, Nancy? First thing, you already mentioned.
The jaw lift, yeah.
Right. The jaw lift is so painful that it can just kind of initiate somebody
Right.
to breathe, okay? So one thing I think is really important also is a lot of us like to use, I put on a 100% non-rebreather venting mask whenever I do an upper. The reason for that is that we can have apneic oxygenation,
Right.
passive diffusion of oxygen into the alveoli without having any sort of
respiratory
diaphragmatic
effort,
or
right.
respiratory effort. You can actually have apneic oxygenation for 11 minutes in a healthy person. And the only thing that prevents you from having more than 11 minutes is that the CO2 gets up so high
Right.
that then you get acidosis and poor effects from that increase in CO2. All right?
That CO2 will knock out your respiratory tract.
That will knock
once
out-
It will just stop breathing.
So that venting mask, that 100% venting mask, it's like a CPAP, okay? It's like just constantly throwing in that oxygen. So it buys you a lot of time, okay? Let's say nothing's working with our respiratory situation and the patient's not breathing, our SAT's not responding, we have to then pull out the
ET tube and the laryngoscope,
And-
or the bag.
and the emblue bag, okay? And the key for the emblue bag is to have an adequate mask fit. 2 people, okay? Yes, can you emblue somebody with one person? Of course you can. But the best thing is with 2 people. So either Nancy's doing the jaw lift and I'm squeezing the bag, or I'm doing the jaw lift and Nancy's squeezing the bag. And we want to see the chest moving, okay? If the chest isn't moving, what does that mean?
It's not on right.
One, it can't be on right, okay? What else can it mean? If
You're filling up the belly.
We're filling up the belly, okay? Reposition. And the worst thing would be like laryngospasm, okay? Theoretically, that laryngospasm should break, okay? If we just keep doing positive pressure on that emblue bag, okay? And then
And
the
then when
worst,
you do bag somebody, you want an effective,
yeah,
you don't want to do this with the emblue bag because you're not allowing that patient to blow off CO2. So you want to have an effective squeeze. You do sometimes initially will bag them a little bit more rapid to get their O2 up, but you just want an effective squeeze.
Yeah.
Let them blow off the CO2.
well,
Can we put an airway without an order? Like,
Absolutely.
if there was
Yeah.
no doctor around, we could.
put one of these in?
Yeah.
Yeah, absolutely.
Absolutely.
The best way to put an oral airway in
Yeah,
my
the technique show.
my opinion is to use the tongue blade to open up the mouth. I'm a righty, so I use the tongue blade to open and then pull forward like a jaw lift. And then I'm gonna put this in, and then the way to seat it is to do a jaw lift, and it'll just kind of like drop on back in.
So Janine, you're never going to do up and then rotate down, correct?
Correct.
Trachs you do. When if somebody's trach falls out, then you can't. Yeah, you usually don't. With a trach, you'll go up and then down to replace it, but an airway usually not. It could cause, it's just like anything. It could cause trauma.
Right.
All of them do that?
That's actually the way to do it. Is
This
what
is-
she's saying.
Not me.
I mean, you will see it like this and then like this, but.
Okay. All right, so we just wanted to just familiarize everybody, the LMA, okay? The LMA is basically the same thing as ambooing somebody, but your hands are free, okay? It's not a protected airway, okay? It's gonna sit over the glottic structure, and if you don't have this seated right, you can be insufflating the stomach just as much as you can insufflate the stomach with a poor amboo bag fit, okay? Endotracheal tube, all right? Endotracheal tube, the port for the cuff, it needs about 5
That's right,
cc's
and you
of air.
need a syringe, because if that cuff is enough, then you're
No good.
NG.
You need a 10 cc syringe. This is the stylet for the endotracheal tube, okay? It goes in to the end, laryngoscope, okay? It's got a blade and a handle. You might want to just kind of take a look at this in case you find yourself in a situation, which is very unlikely, but it's always good to know how to put it on.
Do you have straight or just
Okay.
curved?
We have just the curves
Yeah,
here.
safer, yeah.
Okay. And one thing we were talked about with Nancy and with Diane, is that I know that all of the anesthesiologists have our own carts and everything is different. We're gonna try to do a united front in terms of labeling the drawers. Like, where's the laryngoscope in your cart? Where's your endotracheal tube? Where are your oral airways? So when you guys are there in an emergency to help us, you're not doing this, okay? And if I'm going in to help my colleague, I'm not doing that because I don't know where, Drexel keeps whatever, okay? Anything else, Nancy, you wanna
Sizes
add?
of what? ET tubes? What do you have, what do you have for 8?
We have basically 7 through 8, any size will do,
As long as you get in the
okay,
airway,
as long
yeah.
as it gets in. Preferably a smaller one, like a 7. The smaller the tube, the easier it is to get in, quite
Where does it say
honestly.
the size?
We have 6.5.
It says it right on.
Right here, 7.0, see that? And it also says it here, 7.0. Okay?
You have no way of pyrolyzing anybody here, correct?
Yes, we have rocuronium in
Oh,
the
okay.
refrigerator.
Okay.
Okay, if we had to. All right. Anything else, Nancy, did we not cover?
No, I
talked
think
about?
that's good. I mean, it's just, it's just like anything. I mean, it's all nicey nice. We stand here, we talk about it when it happens. Look, it's human nature. People kind of stop and they're like, oh my